If there's one thing that completely defines the field of surgery, it's that our history is constantly evolving. I mean, what was considered absolute, untouchable textbook dogma 10 or 20 years ago, totally overturned today by rigorous, high-quality evidence. So if you're a surgical resident, a medical trainee, or just someone who's fascinated by how clinical science actually advances in the real world, you are absolutely in the right place. In this explainer, we're looking at 5 landmark clinical trials that fundamentally changed what happens in the operating room.
Here's our roadmap for today. We're going to get high-yield mastery of these 5 crucial case files. The Stitch trial for laparotomy closures, CODA for emergency triage, COLOR 2 for rectal cancer surgery, the Dutch trial for gastric cancer node dissections, and finally CRASH 2 for tranexamic acid timing. Okay, let's dive right into this first one, the Stitch trial on laparotomy closure rules, published in The Lancet back in 2015. Think about this. If 1 out of every 5 abdominal incisions you close in the OR is destined to fail, who's really to blame? Is it the patient's poor tissue quality? Or is it your technique? For decades, surgical textbooks drilled a very dogmatic rule into our heads, right? Big bites, thick suture, 1 centimeter apart. But the Stitch trial came along and completely shattered that assumption.
To understand why that old rule failed, we just have to look at the mechanics. When you close an abdomen, fascial tearing doesn't usually happen because your suture snaps. No, it happens because your suture cuts through the patient's tissue, literally like a cheese wire under tension. It's kind of like buttoning a really tight coat. If you only use 3 giant buttons, all that pulling force concentrates at just those 3 points, tearing the fabric. But if you put in 20 small, closely spaced stitches, that force spreads out evenly. The ST trial set out to test this exact mechanical theory on real patients.
And the results? By randomizing patients to large bites versus small bites, the researchers found that incisional hernias dropped from 21% in the large bite group to just 13% in the small bite group at 1 year. That is a massive 38% relative risk reduction. And they got that simply by modifying suture technique. No fancy new meshes, no incredibly expensive devices, just changing how the surgeon uses their hands.
Based on this data, the European Hernia Society completely rewrote their recommendations. So when you're closing a midline today, you need a 4-to-1 suture-to-wound length ratio. You switch to a thinner 2.0 PDS on a small needle. You take tiny 5mm bites of the aponeurosis only. Seriously, no muscle, no fat. And you space them exactly 5mm apart. The golden rule you need to take away from this: tension is the absolute enemy. You pull just enough to approximate the tissue edges, but never, ever strangulate them. Moving right along to our second case file, let's shift our focus over to emergency triage with the CODA trial, antibiotics versus appendectomy.
Now, for well over a century, acute appendicitis meant one absolute, undeniable thing: an emergency appendectomy. But the 2020 CODA trial challenged that century-old assumption. They asked, can a patient safely walk out of the emergency department with just a prescription, entirely avoiding the operating room?
To really grasp what they found, we have to look at the physical pathology. Think of acute appendicitis a bit like a clogged drain. If the blockage is just mucosal swelling and bacterial overgrowth, well, it's like a slow drain. Pouring some drain cleaner down it, or, in our clinical case, giving broad-spectrum IV antibiotics, might actually clear the congestion without ever needing to call a plumber. But if there's an appendicolith, a literal calcified stone jammed in the pipe, antibiotics might soothe the swelling for a bit, but that physical obstruction, it isn't going anywhere.
So what did the data actually show us? The CODA trial was massive, randomizing over 1,500 patients. And at 30 days, antibiotics actually met the criteria for non-inferiority compared to surgery when looking at overall health status. But here's the absolutely critical caveat. By 90 days, 29% of those antibiotic patients ended up needing an appendectomy anyway. And for the patients who had an appendiculith venable on their CT scan, they had a greater than 40% chance of treatment failure, plus a much higher risk of complications like perforation.
Because of this trial, guidelines from major societies like the WSCS and ACS now acknowledge that non-operative management is an acceptable initial alternative. That's especially true for uncomplicated cases or high-risk surgical candidates. But appendectomy undeniably remains the definitive gold standard. Why this matters for you on call is that you can now counsel your patients using real, hard risk percentages, not just gut feelings. You can tell them exactly what their chances are of ending up in the OR regardless.
All right. Let's move to our third case file, the COLOR I trial, looking at rectal cancer surgery.
Operating deep within a narrow male pelvis using long, rigid laparoscopic instruments is, frankly, like trying to paint a detailed mural through a keyhole. It's incredibly tough. And yet, the oncological requirement for a total mesorectal excision, or TME, demands absolute perfection. You have to remove the rectal tumor wrapped inside an intact mesorectal fascia envelope. Imagine trying to peel an orange without puncturing the inner fruit. The KOLR 2 trial asked a massive question. Does doing this via laparoscopy compromise our cancer margins compared to an open surgery where we literally have our hands inside the patient?
Out of over 1,100 patients, the data was stunning. The 3-year local regional recurrence was 5.0% for laparoscopic versus 5.0% for open, exactly identical. Disease-free survival was actually slightly better in the laparoscopic group, at 74.8% compared to 70.8%. And clear margins? Equal, at 10% for both. The laparoscopic patients got all the added benefits of less blood loss, faster bowel recovery, and shorter hospital stays, all without sacrificing a single ounce of oncological safety.
But we really have to ground this data in reality. The NCCN and ESMO guidelines fully integrated this, validating laparoscopic TME as a highly safe option. However, notice the strict warnings here. It requires high surgeon expertise and credentialing. In fact, KOLR 2 strictly mandated the participating surgeons prove their proficiency first. Plus, special caution is needed for very low rectal tumors. At the end of the day, minimally invasive surgery is only as good as the strict oncological principles maintained by the surgeon wielding the instruments.
Next up, Section 4, Gastric Cancer and Node Dissection. This covers the Dutch Gastric Cancer Group trial.
This one settled a fiercely contested, decades-long debate between Eastern and Western surgical approaches regarding how many lymph nodes to take when removing a stomach cancer. Think of it through an apple tree analogy. A D1 dissection is kind of like picking infected apples directly off the trunk. You only take the nodes attached immediately to the stomach. A D2 dissection, on the other hand, is much more aggressive. It involves pruning the secondary branches along the major blood vessels, like the celiac and splenic arteries. For years, Japanese surgeons swore by the extensive D2 dissection, but Western surgeons, they found it incredibly dangerous.
Let's see how this built into an incredible story of surgical redemption. When the Dutch trial first released its 5-year data, it looked completely disastrous for the D2 approach. Post-operative mortality was a massive 10% compared to just 4% for D1. I mean, it literally seemed like taking more nodes was just killing patients. But look at the 15-year data. Once they followed these exact same patients long-term, the D2 group had significantly lower cancer relapse, 37% versus 48%, and notably better overall survival.
So what was causing all those early deaths? Well, it turns out that early on, Western surgeons were routinely removing the spleen and pancreas just to get to those deeper D2 nodes, which caused massive complications. Today, spleen and pancreas preservation is absolutely key. We leave them alone unless they're directly invaded. You must harvest a minimum of 16 nodes. By abandoning routine splenectomies and centralizing these highly complex cases to high-volume expert centers, D2 lymphadenectomy transformed from a high-morbidity danger zone into the absolute global standard of care.
All right, we've arrived at our 5th and final case file, and it's a huge one. CRASH 2, focusing on tranexamic acid timing.
When a patient suffers massive trauma, their body initiates this terrifying physiological paradox. They bleed, so the body tries to form clots to seal the tears. But severe tissue shock triggers something called hyperfibrinolysis, where enzymes start eating the fresh clots before they can even work. It's like laying down wet cement to patch a leaking basement wall, but a flood of water just washes the cement away before it can cure. Tranexamic acid, or TXA, acts as a chemical hardener to stop those enzymes. But the CRASH 2 trials spanning 40 countries revealed a shocking caveat about exactly when you give it.
Timing is absolutely everything here. If you give TXA within 1 hour of injury, the risk of bleeding death drops by an incredible 32%. If you give it between 1 and 3 hours, it drops by 21%. But here is the absolute shocker. If you administer TXA after 3 hours, you actually increase the patient's risk of death. Why? Because late in trauma, the body shifts from dissolving clots to overproducing them. Giving TXA late promotes microvascular thrombosis and multiple organ failure.
This single trial completely rewrote trauma resuscitation guidelines across the globe. Look at modern massive transfusion protocols from NICE or ATLS. Rule number 1 is basically in bold. Do not administer TXA greater than 3 hours post-injury. If the patient is within the window, you give a 1 gram IV bolus over 10 minutes, followed by a 1 gram infusion over 8 hours. In trauma, time isn't just tissue, time is quite literally survival.
So we've covered small bites, antibiotics, surgical keyholes, no dissections, and trauma timelines. But I want to leave you with this final provocative thought. If evidence continuously rewrites surgical history, what dogmatic rule of today will be debunked tomorrow? Thanks so much for joining me on this explainer and for focusing your time on mastering the data that truly matters for our patients. Stay curious, keep questioning the evidence, and I'll catch you next time.